are in to distribute real quick. So let's start maybe. Oh, you're recording. Okay.
No, I didn't do that.
Oh, it must have been Melissa then.
It was me.
Oh, okay.
Thanks, Melissa. So we should start maybe, let's say, in about like 4 or 5 minutes. Is that okay?
Yep, that's fine.
Sharing.
Yep. Thanks.
Guys, that was more interesting than my talk. So I think we can give CME credit and call it a day.
Ah,
I gotta figure out how to screen share. What is it?
The share button.
Oh yeah.
I can set up the name.
This guy.
Yep.
All right, now
And then hit share, the blue button.
were you gonna? Oh,
Yeah.
yeah, you did
You
introduce.
can
No,
do a
no.
slideshow.
No.
Either at the bottom or you go
Button at the
to,
bottom,
yeah.
right there.
This one?
Yep, that one.
Okay.
I see it.
All right, more
Perfect.
business. So I originally made this many months ago with the plan to just kind of talk to some of the psych residents and other fellows that haven't used ketamine. So it may be a little less interesting. I tried to add some kind of addiction relevant stuff to it, but a lot of this is just kind of an overview of ketamine because I like ketamine and I use it a lot in the emergency department. And Sarah, please jump in at any point in how you use ketamine. Not recreationally. So
Well, it has a role though in withdrawal management.
it does.
Yeah.
It does. It does.
So.
But I think a lot of this is anyway. So Google tells me this is the structure of ketamine. And so I put a picture of it here. And it goes by many, many names. There are more, but I put some of those here. I think vitamin K is a common one, and I've heard cat Valium a whole bunch. But there are many names. It has a fairly unique history, which is kind of fun to look at. I can't remember who this guy is, but he's one of the people that synthesized it. But essentially PCP was identified as an anesthetic, but it had a lot of issues, both in terms of dissociation and also seizures and other things. And so the goal is kind of to find something similar, but less severe. And so that's how we developed ketamine, which is slightly less potent, but still has some of the same effects. And so really the 60s is when it was first being used. I found this published paper from 1966, which had a lot of kind of case reports from age 6 weeks to 86 years old in terms of being used. I can only find the first page of it, which is there. I couldn't find the rest of the paper without paying. I was very curious to see what they gave this 6-week-old ketamine for. But so it's first published in the 60s and then is approved for clinical use in 1970. That's kind of some basic history. So what is it? So it's an NMDA receptor antagonist primarily. There are two stereoisomers, which has some clinical utility, like S-ketamine, which we'll talk about briefly, but it also just acts, it has many, many targets, serotonin, dopamine. It interacts with the endocannabinoid system. I can't remember how it does that. Increases 2-AG or something, but it works just throughout many, many receptor types. And so I guess why we were talking about it and why it's unique. It's kind of unique because it's an anesthetic that works via NMDA receptors. And unlike GABA, which is common in other sedatives, or when we think about hallucinogens and dissociatives in general, we think about serotonin typically. So it's unique in that regard. It's also unique in that it kind of has this dose-dependent function, which is really useful clinically. So I'll talk more about dosing, but you kind of have, like, on the lower end, good pain relief without dissociation, and then you can get completely dissociated, which is used in anesthesia, and then there's this danger zone in the middle, which is used recreationally and also sometimes inadvertently happens clinically. And so the other cool thing about it is you can give people anesthesia or sedation, and you can maintain a lot of their reflexes, including their respiratory function. And so it's really useful in that regards, both for pain, for painful procedures, and also for things like agitation. So I mentioned it has a lot of effects. So it can just, I just found this interesting in that it can cause both positive and negative effects, and actually can be used as a model for schizophrenia. I read a few different papers and a meta-analysis which said typically the positive symptoms exceed the negative symptoms. But I just thought that was kind of an interesting characteristic of ketamine. There are some related substances. I can't say these words. I don't know if any of the toxicologists are here that want to chime in, but so PCP, which we talked about, some other things used in research. Dextromethorphan is a common thing. It's an interesting substance in general. We see a lot of it in adolescents. I think it's actually an analog of an opioid, of codeine, but it doesn't actually interact with the opioid receptor so much. But certainly a dissociative. Nitrous oxide, I think, gets lumped in here sometimes, but generally, I actually don't fully understand the mechanism, but more of an inhalant, but will often be lumped in. Formulations of ketamine, there are many. There's the IV, which we're all familiar with, or IM. There is nasal, what's the blanking on the brand name of that now, but and then there are the troches, are typically compounded oral formulations, which is what's used a lot in ketamine clinics, and we'll talk a little bit more about some of the uses of that. So this is there, Spravato. This is just some general information about it, and a picture I like, which kind of just hints at the dosing, dose dependent effects. But primarily it's FDA approved for anesthesia and sedation, and then there's this more recent monotherapy for treatment resistant depression. I can't remember if it can be used as
Nasal
yeah, it's nasal, and
or IV.
it's monotherapy after I think failed 2 other treatments. I don't. In any case, but it's used off-label for many things, like I mentioned, pain and agitation, and there are a lot of novel uses, like topical ketamine, which I did not know about, which is I think used with amitriptyline and lidocaine for radiation-associated pruritus and pain. So a lot of kind of novel uses out there. I put a lot of charts in here just to kind of give an idea of the dosing ranges. This one, I think there's a better one coming up, which is more straightforward, but just to give an idea of some general dosing and uses of ketamine. There's the anesthesia doses and procedural sedation doses. I usually use 1 milligram per kilogram IV, either for a painful procedure or post-intubation. Pain is substantially lower. Usually, I mean, I usually do 0.3 milligrams per kilogram over like 15 or 20 minutes, but you can also just give pushes. And then the psychiatric use, I can't really speak on, but I think as an off-label use, especially in clinics, a common dosing that I saw was infusions of kind of subdissociative doses over 30 minutes to an hour. This is I think a much better table in how I think about it. And really, you either want to be at the top of this chart or you want to be at the bottom, and you really want to avoid the middle as much as possible clinically. We've all learned this mistake, I think, by giving pushes for pain.
This is where the psychiatric dosing is targeting, right in that middle.
Yeah.
Yeah.
5. Yeah.
And
Yep.
I would not want to do this in a clinic because I've seen it go bad.
Yeah.
But this is kind of the K-hole.
Yeah. Yeah.
So
Yeah.
that's the
Yep.
K-hole range in the
Mhm.
middle. But usually clinically, in emergency medicine, I'll use the top or the bottom. So this is just a table I stole from a paper with a couple of decent studies, just looking at its use for pain. I think the big picture here is just compared to opioids, it's effective, it lasts a long time, it works quickly. Typically, and we'll talk about some of the adverse events that are possible from ketamine, it's pretty safe. but has pretty potent analgesic, which is another benefit compared to something like propofol or procedural sedation, which isn't, I think is forgotten clinically a lot, that you're not treating their pain with that, you're just putting them to sleep. So agitation is another use I mentioned that's off-label but widely used, and in Minneapolis is especially is fairly controversial, which I have a slide on. But I think the thing to know with ketamine with agitation is it can be used IM. It's used heavily in the EMS world. You usually dose it at 4 to 5 milligrams per kilogram. You can repeat the dosing. It typically, like I said, preserves, especially IM, the respiratory drive, and so it requires less intense monitoring. So it's used pretty widely, and it's safe usually in agitation. But like I mentioned, there's some controversy. I just took a couple screenshots here.
Yeah, so this is the liquid handcuffs, right? They
Yes,
use,
yeah,
and there's been some overuse of that in some
yeah, and I kind
incarceration
of,
and police settings. Yeah.
yep, exactly. I lived through this in residency. Some of these headlines from Andy Mannix were from when I was leaving residency at Hennepin, but this had a big impact on the institution, and
Right, where's that at now? Is it being used in the rigs?
it is still widely, I think, probably as a primary agent. I think also droperidol, but it's still used pretty heavily. Sarah can speak to that, but
More droperidol now initially, but if it's like somebody's not
Oh.
responding well, then that's ketamine usually.
Are they still allowed to use it in the carceral system? Do we know?
In the what?
Carceral system? That was part of my
Oh.
concern, if they were actually using it sometimes, like,
not that I know of.
okay.
And I think there's been a much more focus on no police intervention in clinical decisions, but that was a big issue, I think.
Yeah.
Was, police directing EMS to use ketamine, and a lot of issues with systemic racism and agitated delirium or excited delirium as a term which is no longer used.
Yeah,
Yeah.
So uses in addiction medicine. So I think there are a lot of targets, a lot of potential targets, and a lot of interest in this. I think the low-hanging fruit is just using it for refractory withdrawal, for precipitated opioid withdrawal, or even severe alcohol withdrawal and delirium tremens in the ICU. There is also some literature on using it for actual use disorders. I took a few screenshots of some studies I read, which are kind of interesting, but low quality evidence. But there's one paper that gave like a single infusion of ketamine at the psychiatric dose with some kind of mindfulness and CBT, and showed a reduction in cocaine use and increased abstinence over the following, I think, year. And there are some interesting AI studies just kind of mining through like post-operative literature where patients got ketamine for anesthesia and looking and seeing what happened on follow-up with their co-occurring use disorder of stimulants. And seems like there might be some promise there. But again, low quality evidence, a lot of active clinical studies going on right now. And then buprenorphine inductions, I have another slide on this, but it is being used for that also. I think I have a slide coming up. Alcohol, I think, just kind of is an interesting concept, both for withdrawal symptoms, but also for the use disorder. But I think it's just a different way to target alcohol use disorder within an MDA receptor. There's again not a ton of data on this. I found this review and just gave you an idea of how many papers are actually included in this study, to give you an idea of how much is out there on this, which is sorry, I might minimize this so you guys can see. Nope, that's the wrong way. Uh-oh. How do I go back? Here, you do it.
Yeah.
Sorry, I hit the wrong button.
Close the chat. What's your view? How did you do this?
I don't know.
View up there now? You see it up to the right?
right.
Oh, there it is. There's your view button. Interesting. Okay.
Nope.
And now, there's the presentation. Sorry, guys. Thank you. Okay, can you guys still see the shared or no?
Oh, there we go. Oh, wait, no.
All right, somebody else do this. I'm not doing it right. Sorry, guys. Anyone know?
Maybe.
No, we can. It's part of the problem.
Is there anything to click under you are screen sharing? That green,
Yeah.
like if you do the drop down or anything?
Okay, how do we get that back?
Maybe just minimize this,
Yeah, maybe minimize this.
it's like all together.
Here.
Maybe we have to stop sharing and go back. to
Here you go. You
screen
may have to
share.
hit escape and yeah, I can't get to the. There you go. That might do it.
Okay, can we still see
And then
it?
that little bar
Let's
should make it.
Yeah.
Yes.
There we
All
are.
right, we're in business, sorry. Okay, we just couldn't see half the screens. My
Oh,
bad.
and the green one, now you can click on
Oh.
it too.
So, Jesus.
I'm glad to know that nothing has changed about that room.
That
Yeah,
should
the
just-
bottom arrow on that green. You can. Oh,
All
right there. Yeah, there you go.
Wow, it's my final test of fellowship.
Yep.
Okay. Whew. And then this is just, again, there are several papers on using ketamine for buprenorphine induction. The one that's probably most cited is the top left, this kind of case series, in which ketamine troches were prescribed to help people with a history of precipitated withdrawal or real fear of precipitated withdrawal, transition from fentanyl to buprenorphine. It was I forget how many patients were in the study, but I think I have another slide on that. But essentially, using it for both precipitated withdrawal and also just as a to help, I guess the theory to help mitigate the potential for precipitated withdrawal for people that have had difficulty with inductions in the past. And this is a chart from the paper. I think their inclusion criteria was people again transitioning from fentanyl to buprenorphine with a history of precipitated withdrawal or fear of it, and they prescribed 16 milligram troches 4 times a day for the patient to use as home. The induction methods for buprenorphine varied. It was all along the spectrum of the low dose induction, though, usually over 4 days. But I like this table because it gives an idea of the bioavailability of the oral ketamine, which is very, very low, and so probably quite safe for people to use at home. In terms of downsides, there's a lot of fear, at least, yeah, I think there's still a lot of fear around ketamine. I think this comes up a decent amount when I suggest it on inpatient consult services. But some of it's valid, some is not. Emergence phenomena I talked a little bit about, I'll talk about again. That's real. Respiratory depression is really just an issue based on how fast you push it IV. It's fairly rare. It's fairly transient apnea. I don't know, Sarah, if you've seen a ton of it.
Very early.
The nurses are experienced. I think when you work in a smaller facility or with newer nurses, you have to remind them not to just push it in aggressively. But even so, it's generally brief. Laryngospasm is rare, more common in kids or people with URIs. I think it's over-reported. I've seen it once, and I only know that's what it was because I had a video laryngoscope in when I saw the spasm, and then the patient locked down. So it happens. It's very, very rare. Psychosis. This is kind of interesting because of the, I mentioned it can be used as a model for schizophrenia, especially with the negative symptoms. I found a meta-analysis about this that it does induce psychosis more in people with schizophrenia than not, but everyone seemed to return to baseline and did not increase psychiatric admissions. So it can be used, but it is a consideration, especially for anesthesia. Use in increased intracranial pressure and intraocular pressure. I think this should not be a consideration, but used to be taught, at least when I was in med school, to avoid ketamine. And if concerned for these like head bleeds or globe injuries. And then I think people just worry a little bit too much about the intense monitoring required after people get this for pain or after procedural sedation. But again, it's, I think, much safer generally than opioids, especially for Versed and fentanyl, which is still used for a lot of sedations. Here's another table I saw, which basically just talks about the rate of some of those things that I had mentioned. I think just highlighting that generally speaking, it's quite safe. Vomiting is certainly a thing. I don't know that it's something I really run into a lot though, but I guess is a consideration. But I think we consider this for every procedural sedation, so not a huge issue. And then the emergence reaction, there are a few papers which suggest pre-treating with benzos in adults can be helpful. Maybe I've not done that before, and I certainly don't give benzos to kids. I turn the lights off and have their parents hold them, and it goes away. So less of a big deal.
What does it look like in adults?
What do you mean? I'm sorry. Could you
Uh,
explain what you mean by emergence reaction as they're
Yeah.
coming out of it? Is that what you mean?
Yeah, I think I have a slide on it, but I tried to find a video of somebody showing it, but I couldn't find a good one. Oh, here we go. So it can be mild in that people are just tripping. It can be very, very severe in that they're very agitated, pulling their IVs out, trying to escape. They think you're a monster. It can be really, really, really profound and really scary, and they can hurt themselves and they can hurt other people. That's the extreme of it. And we've all seen it when we use it. So the incidence of this, again, the papers are all over the place. I found this, like the biggest review I found said the incidence is 2 to 55%, which is just like
Wow.
a useless statistic in my mind. But usually people are just confused and frightened, and you remove the stimulus in the room and you talk to them calmly, and you also try to set the scene a little bit before the sedation with a calming environment. And it usually is fairly mild, but sometimes it's just severe agitation.
Is this more like, is this a dose dependent, like when you're in the really, really higher dose range, or is it length of time or anything that?
It's usually
Just kind of
either
random.
if you dose it in the middle and you just get you get poor dosing. So it's either that or it's just completely unpredictable. You gave the correct dose, the procedure was fine, they're waking up and it happens. And it's my understanding is there's really no way to predict it.
Gotcha.
Um, so we used to, well, they used to teach to give benzos to pre-treat this, to prevent it in adults and kids. It's been studied in pediatric population. It doesn't reduce the occurrence of this whatsoever. In adults, maybe there's some evidence that you can either treat it or give a low dose of benzos before you give ketamine. I don't do that. I don't know.
I've done antipsychotics if it develops after the fact, but I've never pre-treated.
But yeah, I couldn't find a good video on YouTube because it is kind of an interesting thing to witness, but I thought maybe somebody would have put a video up.
Is it more common in kids than adults?
In my experience, yes. I don't have any, that's an anecdote though. I don't know. The literature on that.
I've seen it a decent in adults too.
Yeah, I kind of see it in everybody. I think I see it more often.
Okay.
But
And how long does this usually last?
it can last a hefty amount of time, like 15 to 30 minutes or so.
But this shouldn't occur if we're using it for pain or substance use treatment, right? This is going to be only if we're doing it for sedation.
Yeah, it's either if you get in the subdissociative dose, like,
Yeah,
or the
full blown.
full blown. For the pain dose, you should not
a
have
pain dose or for substance,
Yeah.
right? Withdrawal management,
Right.
shouldn't be
Where
doing that.
people get into trouble is by giving pushes of ketamine for pain.
Okay.
So especially if you don't know a patient's weight, it's very common for someone to get like 20 or 30 milligrams of ketamine just push, especially in a trauma or something. And this either overshoots or they get redosed, and then you're like firmly in that 0.5 to 0.6 mgs per kg accident.
Gotcha.
So it can happen inadvertently when
Yeah.
treating pain for that reason.
Sure.
Mhm.
Oh, yeah.
Yeah, I mean,
Uh,
I liked it. So just some kind of trends. This is from Monitoring the Future, just in terms of adolescent use. It kind of hovered like throughout the years, relatively stable. It's had a slight decrease in recent years when, especially in the high school age range. I couldn't find any firm statistics on adults. These are some quotes from this study, just in terms of what happens when people have chronic ketamine use disorder. It really does seem to have some lasting impacts on cognition, memory, functional MRI, and just MRI in general has shown some decrease in, or pretty substantial white matter abnormalities in people with really heavy use. So yeah, this is a lazy slide where I just took quotes, but
Do you have a picture of Musk on here? You did that.
no,
Yeah.
I was
Just go
actually
that far.
scared if I put Elon
Yes.
Musk on
Yeah,
here, he
yeah.
would find it.
Yeah.
So I did.
That's true.
Yeah,
That's true.
okay, yeah.
There's also bladder issues, right?
Yeah.
With repetitive use.
There is bladder issues with repetitive use. It can people will often be treated over and over and over for UTIs for cystitis type symptoms. Can also have incontinence. Yeah. There's no real treatment for this. I found one case study using Lamictal. It wasn't very convincing, but it's mechanistically possibly has some benefit. Same thing with the pyramid, which I think just increasingly has been shown to help with like every substance if you can get people to a therapeutic dose. And then the rest of this is harm reduction, psychosocial support. Intoxication. I think the big thing is just, if they're using other substances, don't forget naloxone if they're not breathing. And then otherwise it's just your typical treatments. But I think the real big thing is a lot of times with this, similar to in my experience with like LSD and some other hallucinogens, you can turn the light off and just remove the stimulus. And a lot of times this can improve without any big interventions, but it can take some time, especially with ketamine. Those are references, and that's all I got. I will try to answer questions. How do I get the people back on here now?
It's stop share.
Stop sharing
There we go.
and
Now you can go to
go to
view.
I have
view
seen,
and you could do the
Okay.
gallery. View upper.
There you go.
Sorry, Pam, what were you saying?
there are, in some people who get treated for depression with this, or for, treatment-resistant depression. I've heard of people having, a real dysphoria afterwards or during the administration, and that can actually be a reason for discontinuing it. Is that seen, when you use it for other settings, do you think? Or is that something about the infusion, or is that not really very common, or do you know anything about that?
I don't know much about that. It's not, it didn't come up as a common theme in any of the papers I read, but I don't know much about that. I don't
Okay.
know if anyone else is.
And I don't know whether it was just like, they had some dissociative or perceptual effect that, that they interpreted as unpleasant. I don't know. But I was just going to comment too, one of the most dramatic cases I ever saw of ketamine use disorder, the guy was hallucinated and thought he was, I don't know, that he was supposed to kill himself to be with Jesus, and he slit his own throat.
Oh.
He lived and came to treatment, but I mean, that was pretty dramatic. That was my the main case I remember about ketamine use.
Wow. Yeah, that's pretty profound. I think that on a lighter note, one case I remember from ketamine was in the emergency department as a resident, and somebody came in wearing like a banana suit, like he was dressed as a banana, and was just really hallucinating. And my attending asked him he's like, "What did you take?" And he said, "Control of the dance floor." And
Not wrong, not wrong.
Okay.
Sometimes you gotta.
Yep.
you were saying,
And I had a healthcare professional where that was their substance
wow.
of choice, someone working in the ICU.
Mm.
And so
They
They're-
diverting from work.
yes, so occupational risks.
Yeah,
Yeah.
that's a good point. And the biggest source of diversion is from veterinary.
That's what I would imagine.
Veterinarian.
Yeah.
clinics.
It's used a lot.
Yes, I think we did have a veterinarian where that was their substance.
Yeah.
It's all the supply.
Because it's used a lot in animal anesthesia.
Yes, a lot.
Yep. Yep. Common in vets and vet techs, and then also just being stolen from vet clinics, same as nitrous with.
Yeah.
Force drink, that's what they're talking about pretty much, yeah.
It's
The
ivermectin there.
the benefit in substance use disorders is part of that whole like neuroplastic kind of discussion. That's the whatever it's supposed to increase. I don't quite understand how it all works. The brain derived,
Brain,
yeah, neurotrophic factor, BDNF. That's yeah,
BDNF.
that's easier to say than VEGF, but I don't quite understand all that mechanism. Yeah, I'm learning. But is that also what they think is happening in mental health out of curiosity, or do they think it's separate? If anyone knows.
Is just to get some background context, is the idea you're getting increasing neuroplasticity and helping break down those like addictive pathways.
Yes, exactly. And form new healthier kind of associations. And I'm wondering, is that the same thing that
I
we
think
think?
it's the same
is different?
pathway.
Okay,
In
and
depression,
depression, okay.
but I don't think it's a particular pathway either.
I'm just more curious from the dosing, like, because I'm hopeful that the literature, if they do get more of this for a lot of these substances, whether it's psilocybin or ketamine or everything like that, if we can find a way to have a dose that doesn't cause as much dissociation, as much hallucinations, it'll be a lot easier to administer and a lot less likely to be misused. And we can still provide some of that benefit. That's the hope. So just curious. Yeah. Cool.
So Jared, to summarize the use and substance use, I mean, it's all kind of experimental at this point. I mean, there's not enough data to conclude whether it's helpful or not. Is that
Yeah,
correct? Would you say?
I think that's correct. Yeah.
But there are ketamine clinics in town. We've got patients.
Right.
Who was it who had a patient where we looked at the PD, one of our residents here, we looked at the PDMP and they're getting ketamine from a clinic. We didn't know about
Does
it.
that show up on?
Yeah,
I had no
yeah,
idea.
at least there. It doesn't always, but this one, it was actually showing up and the patient's like, oh, yeah. I'm just doing that for wellness. It was a wellness clinic. And it's just, so there's more use of it than we get. You can buy it online through Choice and other platforms, and they do dosing
Sure.
AI algorithms. So, I mean, there's use of it out there, even if it's not, reported.
And that would it would only be in the PDMP if it was prescribed, like
Yeah.
a nasal spray or something.
Yeah.
If
a lot
they're
of it
going to a clinic
online
and
is
getting
not
an
showing up. Yeah.
if they're getting an IV infusion at a clinic, that's not even going to show up, right?
Yep.
Yeah.
Right.
I'm wondering, you guys, I haven't seen that many cases.
We lost you,
I
Ben.
think we lost you, Ben.
May want to kick off your camera.
So much,
This
so
is
much for his
Yeah.
great internet.
disruptive.
He
Sorry.
had. I shouldn't have mentioned the name.
Take the question in the chat.
You're breaking up. We can't understand you.
Yeah, Ben, we can't understand you.
He's still going though.
It might just be so
Like
delayed.
catching up.
Yeah.
Yeah.
So type it in or try turning off your camera, maybe, Ben. We couldn't catch any of that.
let's just go into Christine Matson.
Oh, sorry.
Lost you guys.
Really went to Chris. Sorry. All
There you
right.
go. Hi.
I didn't mean to. Let's just do that.
You can probably copy those three that you sent. Oh, we're waiting for Ben. Anyone else have questions?
Oh yeah, I'm here. Can you hear me?
Yep.
Oh,
Oh, okay.
go ahead.
And so I guess what I was wondering for you guys who have seen, multiple cases, enough camera to talk. Yeah, I can do that. For those of you who have seen, multiple cases, is this the kind of substance like alcohol where people or opioids where people tend to like titrate so that they always have a concentration in their blood at all times? Most depressants people seem to use, in a titrated manner rather than in like a, binge manner. So how do people use it? Do they use it in kind of this titratable manner? And then if it's that, where in that spectrum of intoxication do they like to sit? Do they like to sit kind of in the lower like 0.1 milligram per kilogram or one range or higher where they're spending, where they're pretty sedated? Has anybody, I don't know if there's research about this, but maybe any anecdote from anybody about what the use pattern actually looks like?
So I think it tends to be more like a club drug in that it's used more episodically, and because of that, at least I can't remember which paper this was addressed in one of the papers I looked at. It's less seen as a use disorder or less common just because people tend not to titrate to effect and have continued use. But they tend to the use recreationally tends to hover in the 0.3 to 0.6 mg per kg range to get the dissociative effects. But I think it's just used more like a club drug.
Got it. Got it.
But like with some,
Although I think I have
What?
seen some people who use it,
Yeah.
who start that way and then keep using it because they find it pleasant or they like that effect,
It's reinforcing.
Definitely.
there's some people who start
Yes.
pretty regularly. Yes, there are some.
Yeah,
That's
and that's a
minority.
handful that I've seen, but in those cases, I just have a hard time separating it out from like this, the significance of like the comorbid. Like, I think three of probably the four people that I saw had awful sort of very complex PTSD situations, and it was like, man, it's this it was kind of underneath that diagnostic header that the ketamine started to creep in, and became a, all day, everyday titration. Um, but it doesn't seem like that's the case with a lot of these other people that maybe you're seeing in the ED setting.
But what I don't quite understand is some of the studies, like a single dose or single use of ketamine results in 12 weeks of not use of alcohol. This doesn't really make sense to me why a single use of ketamine.
It's the whole idea that hopefully it's resetting those ingrained pathways. That's the thought. But I would imagine most of the studies are probably doing a series, just like we're doing with like the neuromodulation, right? They're doing a burst normally. They're doing like this set of treatments in a discrete period of time, and they're not doing necessarily maintenance. Do you need a refresher every 3 months? Who knows? That's another question. And then what are you doing after you take it? If you take it and then go right back to what you did before, you're just putting those pathways back in. I mean,
Yeah.
so I think
Most of them combine
exactly.
CBT, etc. Yeah, but
And have any compared the effect of ketamine to other medications we have for alcohol use disorder?
not that I saw.
Either for treatment of withdrawal or for use disorder?
I didn't see anything.
I don't think it's that far along.
Yeah. Would be interesting to know.
Yeah.
I have a question.
Yes,
Yeah.
go ahead.
Hi,
Hi. Hi, Sheila, especially, and
good to hear you.
you.
Yeah.
I just came back from my exercise class and I'm all sweaty and grubby, and otherwise I put my camera on,
For now.
In other words, I look just like I looked during my fellowship. So my question is, for those people that have ketamine use disorder, chronic, ongoing, long-term, is there a unique pattern of withdrawal for that?
Hmm.
Or no, not really, or hard to know, or? I mean,
Hmm.
can you say, oh, this looks like he's withdrawing from ketamine?
Sixth floor, room MB 635.
Nothing that I know of, but I don't know.
Yeah, and nothing that I remember in the few people I've had that had been had ongoing ketamine use.
Sixth floor.
Yeah,
635.
I agree. I don't remember. I mean, when it wore off, I mean, we didn't have to do any further treatment for the patients I saw. I think when they were acutely intoxicated, and agitated, we would use some benzos, but not for withdrawal. There wasn't really a consistent withdrawal pattern,
Okay. So
but
it's
that's
not like,
anecdotal.
it's not like opioids where you just keep using opioids to feel normal, to avoid withdrawal. This is more like you just keep using ketamine because of the high that it gives you, and not because of withdrawal.
Yeah, I would say that's true.
I think that's right.
Okay, thank you.
Anyone else?
Any other questions? Just a reminder, if you want CME credits, please put your email in the chat for me.
I have a quick question. Does anyone here in the group use ketamine for inductions or buprenorphine? Either as a rescue or as like a pre-treatment to reduce?
No.
I used it at Hennepin in the ICU for someone with precipitated withdrawal.
You did?
Yeah.
Gotcha.
Oh,
Yeah.
also, yeah.
I'm just trying to see what
Mhm.
level of uptake we're getting
Yeah,
in
and
practice.
the Hennepin, I don't think anyone's here. The Hennepin OBAC clinic is looking at
Yeah.
giving oral ketamine for inductions, but
Yeah.
it's not happened yet. But
Yeah. And it's in a lot of the protocols now, like the ED bridge protocols and all those kind of things. It's written in there as a rescue.
Yeah.
I'm just thinking we'll see more of it. Yeah,
Mhm.
ED order set. Yeah,
Mhm.
appropriate withdrawal. Yeah. So I do see it in a
Mhm.
lot of, it's in a lot of those now after the California bridge started putting it in, and I see that spreading. I was just curious in the more kind of outpatient context or other places. Fair enough. Thanks.